And just hoping that everybody's okay with the recording. So welcome to the first of our 2021-2022 Canadian Health Workforce Network webinar series. I first of all want to do a land acknowledgement. We are all joining from a variety of different places in this place we call Canada, Turtle Island. So we acknowledge that we are gathered across Canada and territory of First Nations, Inuit, and Métis here where I'm situated, Carolyn and Darlene. Place we know as Ottawa. We are located on unceded territory of the Algonquin Anishinaabe Nation. So we extend our respect to all First Nations, Inuit, and Métis people for their valuable past and present contributions to this land. And we recognize that land acknowledgements are only one small gesture in disrupting Indigenous erasure and dismantling colonial structures. And so just a reminder to everybody about the calls to action from the Truth and Reconciliation Commission and recognizing that we are all treaty people. So I'm going to stop sharing and allow Carolyn to start with her slides. So I would like to welcome our maternity care lead for the Canadian Health Workforce, Carolyn Chamberlain-Rowe, and Darlene Rose, who will be co-presenting today on using geographic and system mapping to understand the factors shaping pregnant people's experiences choosing and accessing maternity care providers in Ontario's Champlain region. So thank you. I'll pass it along to you.
Thank you, Ivy. Welcome, everyone, and thank you for tuning in to this webinar that's being jointly hosted by the Canadian Health Workforce Network and the Canadian Society for the Sociology of Health. As Ivy mentioned, my name is Carolyn Chamberlain-Rowe. I'm a doctoral candidate at the University of Ottawa's Telfer School of Management, a CIHR Health System Impact Fellow with the Champlain Maternal Newborn Regional Program, and the Maternity Care Thematic Lead at the Canadian Health Workforce Network. I'm honored to be co-presenting today with Darlene Rose, the Regional Director of the Champlain Maternal Newborn Regional Program, who served as a principal community partner for the project we will be discussing in today's webinar, which involves using geographics and system mapping to understand the factors that are shaping pregnant people's experiences choosing and accessing a maternity care provider in Ontario's Champlain region. We would like to take this opportunity to acknowledge that this project was funded through a Women's Exchange 15K Challenge grant and a CIHR Health System Impact Fellowship. This project, which constitutes my doctoral dissertation, is being conducted under the supervision of a thesis advisory committee led by Dr. Ivy Bourgeau, in consultation with an advisory committee of community collaborators, and in partnership with the Champlain Maternal Newborn Regional Program. I will now pass it over to Darlene, who will provide some background about both the provincial and regional context that has incited this work.
Thanks so much, Carolyn. And just have to say, really pleased to be here with all of you today. Really just wanted to talk about the importance of this work and just a bit of the unique nature of the Champlain Maternal Newborn Regional Program. We are regional networks of maternal newborn service providers across Eastern Ontario and have been evolving as a network for over decades. And we have a very unique role in terms of supporting many health service providers in our region known now as Ontario Health East, mostly in the areas of knowledge to action, evidence-informed decision-making, supporting implementation of clinical standards, and quality improvement. So we also have a unique opportunity to be able to influence and facilitate local and regional improvements. Oh, sorry. Okay. And we're also part of a much larger network where we can share successes and escalate issues and challenges at a provincial level. So that then, when we were approached to have the opportunity to work with Carolyn, there were a couple of things that were happening at that time. You may be aware of PCMCH's, the Provincial Council for Maternal and Child Health Low Risk Maternal Newborn Strategy. And as well, at the same time, we were also working on a regional health system, maternal newborn health system capacity plan that was launched in April of 2019 that had 10 recommendations in them, and all of them required additional information for us to be able to move forward in developing an action plan. So Carolyn's work was heavily aligned with us being able to move forward in that area. And without further ado, I'll turn you over to her so she can explain her wonderful work.
Great, thank you so much, Darlene. So in response to this locally identified issue, this study first set out to understand how access to the full range of maternity care providers was distributed across the Champlain region, which encompasses Ottawa as well as its surrounding communities, including Pembroke, Hawkesbury, and Carleton Place. Once we had described the distribution of access across the region, we sought to explore the individual organizational and system level factors that were shaping access to the full range of maternity care providers, as well as pregnant people's autonomy in choosing a maternity care provider within this system. Finally, we sought to identify locally relevant solutions that could be effective in alleviating gaps in access and autonomy that we had identified. So in order to achieve these objectives, this project adopted a community-based participatory research approach using a mixed methods design that encompassed two complementary stages. Stage 1 involved quantitative geospatial mapping exercise to assess pregnant people's access to the full range of maternity care providers across the Champlain region. Stage 2 involved a qualitative participatory system dynamic modeling, employing focus group and individual interviews to explore the factors that are either enabling or restricting access and autonomy within the local system. So let's move on to the good stuff, the methods related to our first stage of mapping access to the full range of providers. So drawing on a survey of midwifery practice groups and the CHWN National Physician Database, stage 1 of this study used ArcGIS software to map the service capacity generated by obstetricians, family physicians, and midwives providing intrapartum care across the Champlain region. Drawing on a data request from Bourne, Ontario, the distribution of maternity care service requirements was then added as an additional layer of mapping. Using a variation of the enhanced two-step floating catchment area method, a provider-specific accessibility index score was then calculated for each census aggregate dissemination area within the Champlain LIN, or the Champlain region now. We then produced choropleth maps which visually represent the provider-specific accessibility index scores and allow us to compare relative accessibility within the region and across provider groups. An accessibility index score of 0, which is represented in white on these maps, indicates that the population in this aggregate dissemination area has no access to the provider group in question within the established drive time threshold, in this case, 30 minutes. As scores increase and the shades of purple become darker, relative access to that particular provider group increases. It should be noted that these scores are relative measures that allow us to compare levels of access, but no particular score is a normative threshold for adequacy of access. Luo and Key propose a two-step process to measure geographic accessibility of care and to identify areas of workforce shortage. The fundamental measure upon which the original methodology is built is a provider to population ratio. In order to build on Luo and Key's approach and account for a more nuanced representation of the match between service requirements generated by population health needs and the service capacity generated by provider practice patterns, our adapted methodology replaces provider to population ratios with a service capacity to service requirement ratio. This adapted methodology allowed us, sorry about that, I have some, I'm losing my page here. Great. So this adapted methodology allowed us to account for individual providers' practice patterns when measuring the service capacity they offer within the local maternity care system, and also allowed us to account for the unique demographic and risk profiles of local populations when measuring the maternity care needs they generate. So in the first step of the adaptation methodology, once representative points for providers and populations had been geolocated, all of the population locations that fall within a weighted drive time threshold from each practice location are identified, and a service capacity to requirement ratio is computed for the defined catchment area. Ideally, each geolocated provider's service capacity is measured using the average yearly volume of deliveries they attended as the principal care provider, adjusted for the proportion of care delivered to residents of the Champlain region and for the proportion of care delivered at the practice location at study. Unfortunately, due to data limitations and resource constraints, we were unable to apply an adjustment for the proportion of care delivered to residents of the Champlain region for this exercise. The total service capacity attributed, The total service capacity attributed to a particular provider location represents the sum of the service capacity of all professionals within the provider group whose postal code of practice falls within a particular aggregate dissemination area. The total service requirement input into this step is calculated using the weighted sum of the average yearly volume of births generated by residents of each population location falling within an established drive time threshold from the provider location in question. Whereas service requirements for obstetricians included all births generated by residents, in the case of midwives and family physicians, the service requirements were limited to births classified as low risk. All data input into this mapping represent 3-year averages covering the period between 2015-16 and 17-18. In the second step of this adapted methodology, a provider-specific accessibility index score is produced for each population location by calculating the weighted sum of the service capacity to requirement ratios of all provider locations that fall within the drive time threshold from the population location. Accessibility indices were produced for both 30-minute and 40-minute drive time thresholds. For some population locations, accessibility scores will reflect their combined access to multiple providers' capacity. For example, if you live in central Ottawa, you will likely be able to reach multiple providers within a 30-minute drive time. For others, such as suburban populations, accessibility scores will only reflect access to the service capacity generated by a single provider. And finally, for some rural populations, population locations, they will have absolutely no access to any provider group within the 30-minute drive time, resulting in an accessibility index score of 0. The weighted rings that you see here that were used in this methodology also allow us to account for the distance between patients and providers in our measurement of access. This acknowledges that a provider whose practice location falls about 5 minutes away from your home will provide you with more access than a provider who practices about 25 minutes away from your home. So now let's look at the findings. So what did all of this very geeky methodological work end up producing here? So when we look at the service requirements generated by the population, the residents of the Champlain region generated an average of about 13,000 births per year as a service requirement, of which an average of 55% are classified as low risk as per the PCMCH definition used in the Born Ontario database. As is depicted in these figures, maternity care service requirements for all level of risks are unevenly distributed across the Champlain region, with some aggregate dissemination areas displaying higher volumes of demand for services than others. For example, Barrhaven and Orleans, 2 of Ottawa's major suburbs, appear to generate high volumes of demand for maternity care. One ADA in the Eastern Champlain region, which encompasses the growing rural communities that line the 417, including Limoges, Castleman, the Nation, and Saint-Isidore, also appears to be generating significant demand for services. These figures also demonstrate that not all populations across the Champlain region share the same risk profile, with some aggregate dissemination areas displaying a greater proportion of births categorized as low risk than others. Given the birth rates and the proportion of birth classified as low risk were variable across the region, the adapted methodology's ability to account for the unique demographic and epidemiological profiles of the local population proved to be essential to the validity of our measures of access. As for the service capacity generated by the workforce, the cohort of physicians with postal codes of practice within the Champlain region who attended at least one delivery between 2015-16 and 17-18 included 104 obstetricians and 130 family physicians. At the time of data collection, the midwifery practice groups included in this study encompassed a total of 91 midwives, of which 65 were permanent employees practicing full-time, 6 were permanent employees practicing part-time, 5 were locums, 5 were students, and 10 were on leave. While there are more family physicians than obstetricians in this cohort, obstetricians' level of participation in maternity care sector and the volume of deliveries they attend on a yearly basis far exceeds that of family physicians. In other words, this cohort encompasses a high number of family physicians providing relatively low volumes of interpartum care. For instance, on average, obstetricians in our cohort attended approximately 105 deliveries per year, whereas a family physician attended an average of about 12 deliveries a year. Furthermore, our cohort demonstrated that an obstetrician is not an obstetrician, with OBs engaging in variable levels of activity and participation in interpartum care. As such, our adapted methodology's ability to account for the individual provider's practice patterns when measuring the service capacity they offer into the local maternity care system proved to be essential to the validity of our measures of access. Using a simple headcount-based provider to population ratio would have led us to considerably overestimate access to maternity care provided by family physicians. So, measuring the interaction between these service requirements and these capacity trends using the adapted enhanced two-step floating catchment area methodology, we produce the following maps of access to obstetricians, family physicians who provide interpartum care, and midwives, respectively. As a result, as is illustrated by the accessibility index scores displayed in these maps, our first overarching finding was that access to all three provider groups is inequitably distributed across the Champlain region. When comparing relative accessibility across provider groups, the darker shades displayed in the map representing access to obstetricians translate into an average accessibility index score that is significantly higher than the average accessibility index score for care provided by family physicians or midwives. Focus groups in stage 2 generally regarded access to midwives and family physicians to be both inadequate and inequitably distributed across the region. While participants agreed that access to obstetricians was also inequitably distributed across the region, they deemed it to be generally adequate in urban centers, with some issues surrounding timely access to referrals and heavy workloads adopted by obstetricians to maintain that level of access. In some areas, access to one provider group is compensating for lack of access to others. This allows for access to care without necessarily affording pregnant people with the opportunity to exercise choice of provider. For example, the area surrounding Hawkesbury exhibits high levels of access to family physicians with minimal access to obstetricians and no access to midwifery care. Focus group participants attributed this trend to the model of care that had been established at the local hospital. Similarly, Barry's Bay and Killaloe, pregnant people have relatively high access to midwifery care because of a satellite practice that had been established by one of the midwifery practice groups, but had no access to any other provider group. Finally, with access concentrated in population centers like Ottawa and to a lesser degree Cornwall, Hawkesbury, and Pembroke, a number of smaller rural communities are left with little to no access to any provider group and are forced to drive long distances and leave their communities to access maternity care. For instance, the Ottawa Valley region appears to be significantly underserviced for maternity care, consistently displaying low levels of accessibility across provider groups. Participants in subsequent qualitative consultations partially attributed this trend to the closure of the obstetrical program at Renfrew Victoria Hospital in June of 2014. This provides a clear example of the critical importance of rural obstetrical programs and satellite practices to upholding access to care closer to home and to of the effects of program closures on access to care. We also noted that the ADA in the Eastern Champlain region, which I highlighted as a concentrated source of demand for maternity care earlier in the presentation, also appeared to be significantly underserviced, with low levels of access to family physicians and midwives and no access to obstetricians. This area also appears to be stuck in the middle, forced to drive long distance in all directions to access facilities and provider groups. I would now like to acknowledge some of the limitations of our stage 1 findings. First, the study employs average yearly deliveries attended by as the principal care provider to measure service capacity. This is the most feasible proxy for a course of care available within our current data infrastructure, but does not capture transfers of care during the prenatal or interpartum period. Just give me a second. Second, this study attributed providers' service capacity to an aggregate dissemination area based on their postal code of practice. As a result, the study does not reflect the full breadth of geographic coverage that midwives provide through their home care and may misallocate service capacity of physicians in the event that the postal code of practice available in administrative databases is inaccurate. Third, the most recent year of administrative data that we were able to access was for fiscal year 2017-18. As a result, any trends that have emerged since 2018 are not reflected in these maps. Overall, participants in stage 2 have validated the accessibility maps produced in stage 1, confirming that they reflect their experiences within the system. These consultations also allowed us to mitigate limitations associated with the timeliness of available administrative data by creating opportunities to confirm where trends that are reflected in these maps remain relevant and highlight any areas where change may have occurred. For instance, participants have identified select communities where trends may have shifted due to recent workforce recruitment or attrition. Finally, edge effects are common limitations of geospatial analysis of defined regions that represent artificial rather than absolute boundaries. While data are limited to patients and providers that reside or practice within the region's geographic boundaries, both residents and providers in and around the Champlain region are free to access and provide maternity care services within and beyond those boundaries. Oh, and I have just double clicked to get far too far. So now we're going to move on to stage 2, where we really got into the juicy stuff, the qualitative methods the qualitative findings that allowed us to explain some of the trends that we were seeing in these maps. So in stage 2, semi-structured interviews with policymakers, patients, and providers were conducted across the Champlain region. Participants engaged in the interpretation of quantitative results generated in stage 1, in the exploration of individual, organizational, and system level factors that are enabling or restricting access and autonomy within the local maternity care system, and in the identification of locally relevant policy recommendations. All individual and focus group interviews were audio recorded, transcribed, and coded using NVivo 12 Pro. Now that the thematic analysis of these transcripts is complete, over the coming months, system dynamic modeling techniques described by Kim and Anderson will be used to translate the preliminary findings presented today into a cohesive causal map of the regional maternity care system. Between February 2020 and August 2021, we completed 20 data collection activities with 69 participants, including 20 patients, 28 providers, and 21 policymakers. Using targeted recruitment efforts and stratified purposive sampling, we endeavored to promote equitable representation across subregions, hospitals, stakeholder groups, provider groups, and patient groups. For instance, once we had completed our provider and policymaker focus groups, we completed a series of targeted interviews with representatives of hospital sites that were not represented in our original focus groups to ensure that all sites had the opportunity to share their perspectives and experiences. So let's look at the findings that we were able to collect. When preparing to speak with you today, I considered structuring these findings for stage 2 around the 3 levels of factors we addressed in both our research questions and our interview questions. But in truth, individual, organizational, and system level factors at play within the system are intertwined and cannot be understood discretely. In each of the following slides, which represents a bite-sized piece of the system dynamics we uncovered, you will see that the system level structures shape organizational level policies and practices, which in turn are shaping the individual behaviors of both patients and providers within the Champlain region's local maternity care system. First, participants highlighted the importance of primary care attachment as a gateway to access information, referrals, prenatal care, postpartum care, newborn care, and noted that for many pregnant people across the region, lack of attachment constitutes a significant barrier to access and choice. Participants explained that this lack of attachment was caused by the broader shortage of family physicians, which is worsening due to inadequate replacement of retiring physicians, and the variable participation in maternity care exhibited by family physicians who are available within the current system. The consequences of this lack of attachment included barriers of access to information and referral, and barriers of access to prenatal, postpartum, and newborn care. In order to fill these gaps in access, unattached patients were forced to rely on walk-ins and emergency rooms. Furthermore, at times, lack of attachment resulted in suboptimal use of specialist care. For example, low-risk pregnant people getting referred to obstetricians very early on in pregnancy to receive prenatal care that could otherwise be delivered by their primary care provider, or referred to an obstetrician by a midwife for an antibiotic prescription that could otherwise be filled by their primary care provider. This lack of, no, I am still far too far. Apologies, I'm trying to get back to where I was supposed to be. There we go. At the individual level, in order to exercise autonomous choice, pregnant people must first be informed about the options that are available to them. However, participants expressed that there's a lack of awareness amongst both patients and providers in the region regarding the full range of maternity care provider options available and their relative scopes of practice and models of care. Obstetricians were the most commonly known provider, which meant that they were accepted as the default option by many. As for family physicians, participants described a general lack of awareness about this option unless your primary care provider or their team provides these services. Participants also communicated some lack of awareness about the characteristics of family physicians who provide interpartum care, including that they did not exclusively provide prenatal care, but also engaged in interpartum care, and that they had received specialized training in maternity care. Finally, while participants acknowledged that awareness and demand for midwifery care is growing through word of mouth, they explained that many people remain unaware of this option. This lack of awareness extended to the characteristics of midwifery, including their coverage under OHIP, their ability to practice in hospital, the pain relief options that they can offer, and the breadth and scope of their scope of practice and training. This lack of awareness is shaped by a number of factors that are constraining pregnant people's opportunity to exercise autonomous choice of provider. The current system is characterized by a lack of coordinated informational resources tailored to preconception and early pregnancy, variable support of informed choice by the confirming provider, and variable access to information through personal networks. This places the onus on patients to seek out information, self-select into an appropriate provider group, and navigate access to these services. Under these conditions, two patient categories emerge. The self-informed advocate whose knowledge of the processes and options enables them to assertively navigate access to their provider of choice, and the constrained adherent whose lack of awareness about the processes, options, and characteristics prevents them from exercising choice on time to gain access to their preferred provider. In response to these informational gaps, participants highlighted the value of developing coordinated and tailored educational resources to facilitate informed choice of an appropriate provider by providing evidence-based information about provider options, the characteristics of these providers, their availability within your area, and the process to access their care. While numerous factors influencing choice emerged in our discussions, including risk profile, gender, language, culture, preferred setting, and model of care, participants acknowledged that in the absence of coordinated informational resources to inform these decisions, the most significant factor shaping people's choice of provider was word of mouth and past experiences. Whether this information be transmitted through friends, family, or social media platforms, pregnant people who had become informed self-advocates had often first been made aware of these options through their informal social networks. Through our engagement with local stakeholders, we were able to identify a number of social determinants of access and autonomy that widen the gaps I've just described. Young parents, people whose first language is not English, people who have lower levels of education and literacy, people who have inflexible and/or insecure employment, people who have low incomes, people whose family responsibilities and characteristics tie them more closely to their homes, people who of color, Indigenous peoples, newcomers to Canada and the region, people who lack access to a vehicle or reliable transportation, the LGBTQ2+ community, and people who have mental health and conditions and use substances, all face amplified barriers of access and choice within our local maternity care system. We were also able to deepen our understanding of the geographic determinants of access that are reflected in the maps produced in stage 1. Providers are concentrated in population centers that offer high density of demand and proximity to obstetrical programs. This results in an inequitable distribution of access to the full range of maternity care providers and choice of birth setting across the region, requiring rural populations to drive long distances to access care, which in turn influences the care options that are made available to them. These trends are attenuated by the presence of rural obstetrical program and satellite sites, which are critical to bringing care closer to home for these populations. They are also attenuated by midwives' ability to uncouple access to care from the distribution of facilities and cover large geographic areas through their provision of home care. Finally, since the advent of COVID, the use of virtual care for a subset of prenatal appointments has attenuated some of these barriers. On the other hand, these trends are compounded for patients who have risk profiles requiring frequent visits to tertiary care centers, lack of access to transportation, have inflexible employment models that requires them to sacrifice income in order to attend their appointments or even face inclement weather. One of the key drivers of the inequitable distribution of providers that is shaping these geographic barriers of access are persistent challenges with recruitment and retention of providers in rural settings. Participants explained that these challenges stem from a lack of exposure to, training for, and comfort in rural practice amongst graduating students, new students hesitating to take on the amplified challenges associated with building a new practice in a rural setting, large catchment areas and small practice teams resulting in demanding call schedules and compromised provider well-being. And finally, rural facilities' difficulties generating sufficient volume to maintain competence, ensure the financial viability, and justify the lifestyle of rural providers. Across both rural and urban settings, a vicious cycle of workforce trends appears to be constraining potential access by limiting the service capacity generated by all three provider groups. First, limits on the number of students trained and barriers to the integration of available providers limits workforce supply within the region. This leaves passionate and dedicated providers adopting heavy workloads and demanding lifestyles to meet growing patient demands with limited resources. These heavy workloads are unsustainable, leading to burnout, leaves of absence, and attrition. This is particularly true when providers are required to cover for various types of leave of absence and to compensate for the lost capacity of providers transitioning into retirement without the introduction of new resources. This unsustainable level of activity is leading to decreased participation in interpartum care. Fewer graduates are interested in adopting the lifestyle required to provide interpartum care, and some providers who have the flexibility in their scope of practice to do so are either suspending or decreasing their interpartum activities and on-call work. Participants noted that all of these trends point to a need for a sufficiently large workforce and team to meet population needs while ensuring sustainable workloads and call schedules for providers. Participants also indicated that the current model of remuneration creates competition for limited market share. And when we say market share, we mean women who are or pregnant people. This constrains choice by rendering it challenging for programs and rural programs in particular to generate sufficient volume to maintain the financial viability of all three provider groups. It also impedes interprofessional collaboration by fostering tensions and disincentivizing interprofessional support, and leads to suboptimal use and duplication of resources as a result of the absence of compensation mechanisms for integrated care. Participants explained that alternative remuneration and funding models could support pregnant people's access to the full range of maternity care providers by fostering innovative patient-centered models of collaboration that could provide appropriate levels of care to patients at an appropriate cost to the system. The development of alternative remuneration and funding models is also seen as an opportunity to ensure the financial viability of establishing and maintaining practice, particularly in rural low-volume centers, and supporting flexible work arrangements and retention within the maternity care workforce. Under the current model of remuneration, hospitals are forced to differentially prioritize and support the integration of obstetricians, family physicians, and midwives into their obstetrical programs. First and foremost, hospitals are required to prioritize maintaining the practice viability and retention of obstetricians because of their reliance on obstetricians for gynecological care and surgical backup. There is no obstetrical program without an obstetrician. The retention of obstetricians, therefore, is critical to sustain the sustainability of an obstetrical program. In contrast, it appears that within the current system, certain conditions must be met in order for hospitals to be enabled to support the integration of family physicians and midwives. Hospitals are enabled to support family physicians who provide intrapartum care and midwives under 3 common conditions. The obstetricians have established a viable practice. The hospital is seeking resource-effective program growth by bringing on new low-risk clients, and respectful collaborative relationships have been established between all 3 provider groups. However, family physicians do appear to have an advantage over midwives in many hospitals because many hospitals rely on their contribution across other sectors of care, including pediatrics, neonatal resuscitation, the emergency room, and primary care. This leaves midwives particularly sustainable to the constraints on their privileging and birth volumes, which are used to maintain the practice viability of other maternity care provider groups active within the hospital upon which they rely so heavily. At the organizational level, these facilities, policies, and practices, including caps on birth volumes and privileging that result from these conditions, can pose barriers to the recruitment and optimal integration of providers into the local maternity care workforce. Participants indicated a need for more coordinated leadership at both the regional and provincial level, including the establishment and implementation of a common vision and guidelines in order to foster an enabling environment for collaborative maternity care across facilities and provider groups. I would now like to acknowledge some of the limitations of stage 2. First, while we achieved a reasonably large sample size and endeavored to capture a variety of voices, we do not contend that the participants in this study constitute a representative sample. These findings reflect the perspectives and experience of our participants alone and may or may not reflect the perspectives of other patients, providers, and policymakers across the region. Second, data collection was interrupted in March 2020 due to the emergence of COVID-19 and further delayed by my own maternity leave. As the focus of the study was not the impact of COVID-19 on access and/or choice, when data collection resumed in January 2021, we adjusted our patient inclusion criteria to capture the experiences of pregnant people who had chosen and accessed their provider prior to the emergence of the pandemic. This adjustment to our inclusion criteria also resulted in an adjustment of our patient recruitment strategy. Unfortunately, despite our best efforts, patients who accessed intrapartum care provided by family physicians are underrepresented in our resulting sample. Finally, we must also acknowledge that these findings do not reflect the perspectives of one hospital site within our region and underrepresent the perspectives of certain provider groups who chose not to participate in this study. And now I'm going to pass it back over to Darlene for some concluding remarks and next steps of what these findings mean for CMNRP moving forward.
Just want to make sure people can see me.
Yes, we can see you.
Wonderful. So thank you so much, Carolyn. It has been an incredible journey working with Carolyn on this. And although I wasn't in my position at the time of the conception phase of this project, we certainly went through the pregnancy, labor, and delivery together. I'm so grateful to have been a part of this work. We have many lessons learned throughout it, many anticipated challenges to overcome, largely a global pandemic to name one. But I do want to make sure I acknowledge that Carolyn addressed all of those head on with a healthy balance of persistence, integrity, fortitude, and equanimity. So where does this mean for us, and what does this mean for CMNRP moving forward? Absolutely, this work will further inform and reinforce our strategic planning as we enter into that phase, getting ready for 2022 to 2027. A lot of this information absolutely helped to inform our capacity plan recommendations, largely as we move forward in strategic planning with a focus on the quadruple aim. You can see a lot of this will help inform improving patient experience, improving provider experience, improving maternal and birth outcomes, and somewhat in value for healthcare dollar, depending on how far we get with some system level issues. So we intend to focus on the following areas at the regional or local and regional area, level. There's certainly clear actions we can take along with our health system partners in the areas of person-centered care, collaborative care, health system integration, access to care, intersector and interdisciplinary collaboration, health equity, and culturally safe care. But more specifically, I think the obvious ones are increasing awareness of options for the most appropriate healthcare provider and related scope of practice, in addition to further informing health workforce capacity planning and sustainability issues and challenges, which is top of mind right now and very timely. And in addition to that, continuing to work with our partners on removing some of the perceived anecdotal and real barriers to addressing some of the system level factors shaping pregnant people's experience choosing and accessing a maternity care provider. And because of our unique situation, we can also escalate system level issues beyond our capacity at a regional level to the many provincial tables that we sit on. So thank you so much for that great presentation and contributing to our work at CMNRP.
Great. Thank you so much, Darlene. So that concludes our presentation for today. We did want to leave a healthy amount of time for questions and discussion. So thank you again so much for participating. Darlene's comment about not being there at the inception of this project reminded me, Marie-Josée Trépanier is actually on the call today. And I wanted to give a quick shout out to her because she was the regional director at the time when we did reach out and was instrumental in getting this project funded and on the go off the ground. So of course, thank you for that, Marie-Josée, and thank you for coming today. So we are more than happy to answer your questions and look forward to a fruitful discussion.
Thank you so much, Carolyn. I really appreciate that. And for anybody who would like to pose a question, please do so in the chat. We are a small group, so you can also unmute yourself. And we would like you to introduce yourself very briefly, and especially if you haven't done so in the chat, and pose your questions to Carolyn. And so I think the first set of questions comes from Steve Slade. Please go ahead.
Hi there. Thank you so much, Carolyn and Darlene. That just really wonderfully presented work and such rigorous work. I'm the director of research at the College of Family Physicians of Canada, and I had two questions. They're in the chat, and I think they're kind of related. One is that the maps were fantastic. I just love the maps, and I really like the way that you pointed out these areas that have very different sort of profiles in terms of access, you know, and I was wondering whether or not you had created, I know that your study was about sort of autonomous choice and being able to choose. And so the idea was to break it down, but I couldn't help but think about those areas that are just white across all three of the maps. So I wondered whether, or that have sort of that light purple shading across, and does it add up to a kind of an adequate supply, I guess, you know, overall obstetricians, family physicians, midwives. So that's kind of the first question. And then the second question is this piece around, is there actually competition amongst providers? I wasn't sure if that was a theoretical sort of concept, or if you actually were seeing that in some regions, competition.
So in response to your first question, it's difficult to create a combined map because the service requirement that we're using, or the demand that we're using for family physicians and midwives, is a subset. So it's only low risk births versus obstetricians, which we're including all births. So it's difficult to create a single map and a single accessibility index score that wouldn't underestimate for some and overestimate for others. But we are considering kind of just doing a simple addition, like a summing of the different accessibility index scores for each aggregate dissemination area to see if there's any trends we see there. So absolutely, that's one of the factors. So the scare quotes I used for market share were intentional in that that is literally the way that it is formulated sometimes in our interviews. So we have multiple providers, policymakers, patients talking about the fact that the current model of remuneration and the fee-for-service system does create a competition and kind of territoriality between providers when it comes to this. And it's not only interprofessional, it's also intra-professional. So we have some even obstetricians talking about the fact that it's difficult to convince their colleagues to bring new people onto the team, because even within obstetrics, you're then breaking the pie 13 ways instead of 12. So there's a lot of, the market share is not something that's theoretical, it's something that's actively being discussed by many participants who specifically point to the need for alternative funding and remuneration models, notably kind of salary, everybody on salary and just working together at meeting the needs of the population in order to kind of avoid this kind of dynamic within the workforce and within the market.
That's great, Carolyn. Thank you. I think our next question is from Lori. Please go ahead, Lori.
Hi, thank you. Carolyn and Darlene, so great to be able to hear your presentation today. My question, I have two questions actually. First off, just wondering how is this issue being looked at federally? And the second question is just around what would you suggest other communities do to get started to look at this issue for their own needs?
Yeah, so I might defer to Darlene to see if she's aware of any kind of higher level efforts to conduct this kind of work. I am not aware of any, is specifically looking at this. The methodology that we've adopted and the approach that we've adopted is certainly translatable and adaptable to other settings. So we are currently in the process of applying it to access to mental health and psychotherapy services. And as I transition into my new role, I'm hoping that we'll be able to move this over to Nova Scotia and start looking at some trends there. But we have tried to make sure that we are engaging with the right stakeholders within the provincial system. So we've already had some consultations with PCMCH and other provincial stakeholders to see what interest there is in translating this kind of approach to other regions and getting a broader picture of whether or not our situation is unique, or are these trends really kind of relevant across the province. So I'll move over to Darlene if you have any additions for that.
And no, I think you articulated that really well. I'm certainly not aware of anything from a maternal newborn perspective, specifically at a federal level. There may be some work at a system level across sectors that's happening that others may be able to speak to, but certainly not specifically to maternal newborn.
Thank you. So other comments or questions, and if you'd like to follow up. This is a very interesting methodology, and it's particularly helpful to use such a methodology when you are looking at types of tasks that are not accessible by a distance, right? We've moved a lot of things virtually. We can't deliver babies virtually. So there may be some elements of prenatal care, postnatal care that can be done virtually. But so this is a type of task that really lends itself well to geographic distances. Yeah. So last chance for anybody who would like to pose a question. And also, while you are formulating the question, just to let you know that we will have another another session looking at mental health, not drawing upon the methodology that Carolyn has mentioned, but our mental health lead, Mary Bartram, will be leading a webinar on November 4th at noon. That is looking at the impact of COVID on the capacity of the mental health and substance use workforce. And Carolyn is a member of that team, but the work that she's been doing is still in progress. So we'll be presenting some of what we heard from stakeholder interviews, from a policy dialogue, and what it is we were able to glean from a scoping review of the literature. All right, so I think with that, I will stop the recording. I will pause and close out. Some people have asked when the recording will be posted. We'll do that ASAP. We are a volunteer organization, so we'll do the best that we can. And also to mention, co-sponsoring our event today also was the Canadian Society for Sociology of Health, and my apologies for getting to mention that at the outset. So I very much want to thank Carolyn. I want to thank you, Darlene, and looking forward to our continued conversations. Thanks, everybody.
Thank you.